Adolescent. We are really thrilled to have you. I also forgot to mention his Women's Equality Day. I think everybody knew this, but something like 89 years ago, we got to vote.
Yes.
So, yay us. And I believe Secretary Sebelius at FSU Health and Human Services is having a phone conference call about women in healthcare right now too. So we have come a long, long way. As you say, the grading on the curve thing is really true. So I think we're just going to go right around and take a couple minutes, and I'm just going to say a couple summary things that I know you all will fill in quite a bit. The Women's Consortium has an annual event called Presidents on President's Day. A lot of people here have participated in this. I'm sorry our color print you broke down, so there aren't quite enough in color for everybody, but otherwise there's 2 years ago. So we bring presidents of women's organizations to the state capitol. We usually have a huge laundry list of issues that we work really hard, am I right, paring down to 5 or 6 or some number that is manageable for legislative leaders to hear about. But back in 2008, the group said, you know what, we have got to talk about healthcare and healthcare reform because it is so, so important. And we can't do anything else until we get healthcare. So it was interesting to me looking this up this morning. So it's a pretty long time ago, a year and a half, and yet the issues are still right there. So we need to be inclusive, the disparities, special immigrant populations that we have in Minnesota, which we'll hear more about. We really need that whole package. We just can't have pieces of that package. So you know all the reasons why healthcare reform is a women's issue. I don't think we hear often enough that women are the majority of providers of healthcare as well as consumers. When we think about all the nurses and home health aides, not to mention the moms and the daughters and all those other things that we, in many ways we are in charge of healthcare. We just don't have the power to change it yet. And then there is the ongoing, women are more likely to be uninsured or underinsured compared to men. And then there's this whole group of issues around things like the need for birth control are treated as sort of strange and unusual things that wouldn't be included in a standard package. You know what I mean? So I have long feared the day when we say, yay, healthcare is reformed, everybody has health insurance, but I'm still going to walk in the doctor's office and somebody's going, oh, something with the uterus, that's not covered. That would be weird. We are the majority of the population and our bodies are normal, so we would really like the healthcare system to notice that. The bills, we know there's going to be several things before you, and we're going to try to focus on those a little bit. As far as I can tell, just about anything that you will be looking at will increase the number of people who have health insurance coverage, and obviously that's a good thing, and we need that really badly. There are 225,000 Minnesota women with no health insurance at all, and that is about 8% of white women, which is bad enough, but it's 14% of Asian women, 16% of black women, 26% of Native American women, and 47% of Hispanic women in Minnesota. That is a really large number of people who have zero health insurance. And as you know, there's a lot of special issues with immigrants that were the #1 resettlement location for Somali immigrants, for example, and I think some other groups, so I think some of your people will talk about that. By age groups, there's over 116,000 Minnesota women aged 18 to 44 who have no health insurance at all, which is about 12% of that age group. And that's a pretty important age group, not just for all the reproductive concerns, but for things like prevention of strokes and heart attacks and so on. 18 to 44 is not a good age to not have any health coverage. The public health insurance option, and thank you, you've already been talking about this, but we would like to reinforce that, seems to be the most likely option that would really lower costs and offer real choices for the people who are underinsured, which is another gigantic group. So to just show how that is playing out in Minnesota, about 84% of black women in Minnesota do have health insurance, 84%, but only 76% get an annual dental exam, and only 72% have first trimester prenatal care. So it's people who have insurance but can't take those steps, probably because of the out-of-pocket, the exclusions, the co-pays, and so on. So that's a huge problem. Of course, when you get to age 65, you're eligible for Medicare, but I have sadly learned that does not necessarily solve your financial problems with healthcare either. We've had a special project that has looked at the true cost of living for older people. And even for an older woman in good health, all of your premium copay, deductible, and out-of-pocket costs in Minnesota are going to average about $3,600 a year, which is about 30% of the median retirement income for women in this age group, and that's with your supposedly free Medicare coverage. So there's huge problems. When older people's health goes down to fair or poor, those costs go up to more than $5,000 a year. And people just do not have that money. We have all kinds of programs, but we do not have cash in the pockets of older people. those things. So we've just got to make healthcare affordable for everyone. And then the other piece, the public option seems like the best way to end the harmful industry, healthcare insurance practices, like the pre-existing things you talked about, rejecting people based on things. Minnesota has laws already that prohibit gender rating in some individual and small group insurance plans. So that's a good step, that part of that leadership. But I don't think it's prohibited in the bigger groups and lots of other settings. And there's also, frankly, since these things are regulated at the state level, there's the problem is that if a woman moves away from Minnesota, she's not going to have that coverage anymore. So we really do need some of these things to be uniform nationwide, and we'd like to keep our good Minnesota programs. So comprehensive benefits for the health services that real women need. Of course, it's yet to be determined what all will be considered comprehensive and included, but as far as I can tell, that public option is also the one where it's really medical experts who will look at the science and the evidence and decide what needs to be included and take it out of the political arena where somebody can tell me I shouldn't have access to birth control. So I think that's a very good option, and I think it speaks for a lot of people here. So it's just so clear that the healthcare system is broken for women, although we've done some wonderful things in Minnesota. We have so far yet to go, and so I think that sense of urgency that we really don't want to take 2 or 3 or 4 more years to fix it. We're really excited about having something good happen this year, and we'll probably not be perfect, but we'll be improving. So thank you so much.
Thanks, Bonnie.
Yeah. I just wanted to let folks know we have less than an hour, so in order to get around to everybody, no, I just want to make sure that we give everyone, it looks like about 2 minutes each, just to make sure
Oh my
everyone's heard.
God. Okay, can I just say a couple things? Just a couple things in response, just very shortly. Okay. Family planning, birth control, yes. Comprehensive sex ed, yes. We have to do comprehensive sex ed. This is going to be a universal health care plan. Everybody's covered. Women do tend to work more part-time. Women are paid less, and therefore tend to be more women in the bottom end. Those people at the bottom end will be subsidized. That's what this bill is. This is what the Health Education Labor Management Bill is. Gender rating will be prohibited.